Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Farooq. Dr. Farooq completed a fellowship in pulmonary critical care at Cleveland Metro Health Medical Center, followed by a sleep medicine fellowship at Case Western Reserve University. She currently serves as the interim director of the Asthma Center at the Cleveland Clinic in Ohio and holds the position of associate professor at the Lerner School of Medicine. She also completed a Master of Business Administration at the George Washington University. And now it is my honor to request Dr. Farooq to begin today's session. Thank you.
Good morning, everyone. Good morning, Amna. Can you guys hear me good?
Yes, sounds good.
Okay. All right. Thank you for the introduction. So my name is Dr. Subia Farooq. I am a pulmonary critical care medicine physician in Northeast Ohio. And as Amna said that, I'm an interim director for asthma medicine here at Cleveland Clinic. So my interest is in asthma medicine. So that's what we're going to talk about today. Just a little bit background about myself, since I was told to tell a few things about myself. I did my medical school back in Pakistan. And after finishing the medical school, I came back and joined my family here and took the USMLE, the usual path for international medical graduates, took the USMLE and was able to do the residency and followed by a fellowship in pulmonary critical care medicine and then sleep medicine. I worked in DC area for 4 or 5 years, and then I moved out of the country to work for Cleveland Clinic in Abu Dhabi for about almost 8 years, and I returned back last year. Somewhere in between, I also did the master's in business administration from George Washington University, because of my interest in business aspect of medicine. So here I am, and I do want this session to be interactive. So if, as Amna said, that if you guys have any questions, please feel free to ask, and Amna can let me know. We can do towards the end of the presentation or as you guys see fit. So I wanted to keep this as simple as possible, but you might find this a little bit at times that it might be a little difficult to follow. So if that's the case, please let me know, and I will try to simplify it as much as possible. All right, so let's get started. So we're going to talk about asthma and what we know about asthma so far. So asthma has changed over years, and that's why I wanted to make the title as that, what we know so far, right? So first of all, let me move this thing out of the way because it's distracting. Okay, now we're good. All right, so I wanted to sort of paint the story of asthma for you guys, that what is the story of asthma? Asthma, as you know, I mean, I'm assuming that everyone who's here has the passion towards medicine in some shape and form. So it is one of the very common diseases that we encounter in medicine in general, not just in pulmonary medicine. And so we will talk about what is the definition of asthma. How did the definition evolve over years, over centuries? What is the pathophysiology of asthma? How do we treat asthma? And what is the role of glucocorticoids, which in other words is the steroid? And how is asthma different than COPD? And then we can also discuss a case too. All right. So I'm going to start with a clinical case. So so that you know that, when a patient is in front of you, what would they be complaining about? All right. So I have a patient here. Her name is Pinkalicious. She is 25 years old, and she's referred to you for evaluation of seasonal bronchitis. She reports history of bronchitis for last 5 years. All right. So what is bronchitis? Bronchitis is when someone complains of the cough or the shortness of breath or the wheezing, and they think they got a cold, and then this cold is not going away. Her symptoms start around the end of August, and they persist until winter. The symptoms include frequent coughing, especially at nighttime, tightness in chest, and audible wheezing. she takes the albuterol inhaler, which is a common inhaler that we give our patients to help relieve the symptoms. And she uses it about 3 to 4 times per day during that time of the year. And in last year, she developed an exacerbation, which required hospital admission for several days. As far as her past medical history is concerned, she reports missing school during fall time. Let me just take care of this too. It's hiding my slides. Okay. So she reports missing school during fall due to respiratory tract infections. Her social history is pertinent for smoking during college, which she was smoking about half a pack per day. Her medications included albuterol inhaler as well as the birth control pills. On her physical exam, she had some congestion of her nose. Hyperemia basically means the congestion of the, it's a blood vessel congestion, or there's increased blood flow. And when you listen to her lungs, there is good aeration bilaterally, no wheezing at the time, and no other added sounds or the rhonchi. So PFTs are the pulmonary function testing. And these are the different numbers that we get when we test somebody to check how much lung capacity they have. Do they have trouble exhaling to their best potential and whatnot? And I can tell you I'm not sure how familiar you guys are with the breathing test, but I can tell you just looking at these that, her FEV1, which is forced expiratory volume in 1 second, is about 95%. That's pretty good. The ratio between these two numbers is normal. And then the rest of the lung testing, lung function testing, including lung volumes and diffusion capacity, which is the oxygen transfer across the lung membrane, was also normal. She did not have any bronchodilator response, which basically means that when we test as a baseline and then when we give the inhaler to see if she responded to that, was not there. Okay. So the questions about this patient, right? So the first question is, does this patient have asthma? What is in her history that suggests a diagnosis of asthma? What accounts for seasonality of her symptoms? And can the diagnosis be made based on her spirometry today? And spirometry is the breathing test that we just talked about. So the first question that we would think about is, does this patient even have asthma? Right? And then obviously we are talking about asthma here. So there must be something in this patient's history that suggests that this patient has asthma, right? So if we go back and look at her symptoms or her history, it looks like that she has seasonal bronchitis, number one, or she's labeled as seasonal bronchitis. She has had it for the last 5 years. Her symptoms start around certain time of the year, and then which we see that there's a change in seasons here, right? So in August, and then it persists until early winter. Her symptoms are in the history, one of the most frequent or the most important things that we consider is the symptomatology. That's how you find out from a patient that what is going on. So she's frequently coughing, especially at nighttime, which is something very important that we see in our asthmatic patients. She has been complaining about the chest tightness, and then there's audible wheeze, which is a whistling sound that you would hear from the chest. And then she also reports that the albuterol helps her symptoms, and she uses it about 3 to 4 times per day during that time of the year. And her symptoms were so bad last year that she ended up being admitted in the hospital, right? So the history definitely gives away all those things that include asthma or that are required for asthma. She has, coughing, chest tightness, shortness of breath, wheezing. She has symptoms that are primarily seasonal, and she also has a relief with albuterol or the bronchodilator that she gets, the inhaler that she takes. And so the next, the last question here is, can the diagnosis be made on her spirometry today? So if you look at the spirometry, I told you guys that the spirometry looks completely normal, right? So based on that spirometry, if you didn't know this patient's history, you would say, oh, this spirometry is normal. I don't know if this patient has asthma or not. So the point of stressing this point is that the asthma is a clinical diagnosis as well. You need to know the patient's clinical history. And then you put the testing together, and then you make up your final diagnosis. All right, so let's see, before, we talk about the history of asthma, right? So before we further discuss the evolution of definition of asthma over time, I think it's very important to know how did this definition evolve over time. So that means we have to look into the history of asthma, right? So asthma is one of the ancient diseases discovered. So we have the evidence that, the old Chinese scriptures had, there's evidence that the breathlessness was treated with a ephedra. Then the ancient Egyptians also used inhalational therapies. If you look at these pictures here, that, they treated patients who had breathlessness with some inhalational therapies. And also Hippocrates, who's the father of medicine, he describes the link between respiratory ailments and the environment. Asthma, the word asthma itself comes from a Greek word, which means breathlessness. And then if we, this was hundreds of centuries ago, and if we move forward, one of the major works that was done was Henry Salter, who described the asthma in his book, and which is a famous book in asthma medicine, who described the asthma as paroxysmal dyspnea of a particular or peculiar character with intervals of healthy respiration between attacks. What does that mean? That the patient would have symptoms and a certain with the certain characteristics that we described, and then there will be times that patient will not have any symptomatology in between. Then Dr. Osler, who's considered the father of modern day medicine, he describes asthma very well. He talks about spasm of bronchial muscles. He talks about the asthma includes swelling of the bronchial mucous membranes, and the mucous membranes is the inner lining of the respiratory tract. He also talks about the special form of inflammation of the smaller airways. He suggests that there is a resemblance between this disease and the hay fever. There is a genetic component to that it runs in the families. It often starts into childhood, and sometimes it lasts into the older age. And then he also described, which is something very important, that, a bizarre and extraordinary variety of circumstances, which at times induce a paroxysm. So, which those circumstances like climate change, the atmospheric changes, the exposure to hay, the dust, cats, fright and violent emotions. Then some triggers with the diet, where he talks about the overloading of the stomach for certain foods, cold infections. And now we know in this day and age that, certain things like a diet, if people have acid reflux, the acid reflux can trigger the asthma too. Then asthma got its relationship with allergies later on, and there were a lot of work that was done that asthma is related to weather, again, with the weather changes, infections, exercise, emotional stress. There's also a relationship with the allergens outside. So this is, I thought that this would be an important, this is relatively newer definition, but it still is about 40 years old. The heterogeneity of asthma. It is important to know this because we know that the asthma is not one homogeneous disease. So how it was described at the time was that at present time there is no solidly established and widely agreed upon etiology of asthma. And as we are seeing that, different people have talked about different things, that what could be the etiologies of asthma. Indeed, there may not be a single cause that we may be dealing with a number of diseases that have in common the physiologic finding of reversible obstructive airway changes. In that case, we might speak of asthmas in the same fashion as the hematologists speak of the anemias. So, basically what it hints is that the asthma can come in different flavors. It might not be just one thing that, your asthma might be different than my asthma, or, the third person asthmas could be different. So the modern day definition, which by GINA guidelines, the GINA is the Global Initiative for Asthma. It's a global definition of asthma. So asthma is a heterogeneous disease defined by the history of respiratory symptoms, for example, wheezing, shortness of breath, chest tightness, and cough, that vary over time and in intensity, together with variable expiratory airflow limitation, and airflow limitation may later become persistent. So this is an important thing, that how would the airflow limitation be persistent, right? So we're going to talk about that later on. Or we can talk about that a little bit here. So again, just the basic thing that it is a heterogeneous disease. It can present differently in different people. Some people can just have shortness of breath. Some people can just have feeling that their chest is heavy, or some people have this cough that every time they talk or they laugh, or when they are exposed to the cold environment, they would cough. And it can vary over time. It can vary in intensity. And when we do the breathing test, there are different, people have trouble exhaling, right? So we take a breath in, and when we breathe out, that's where the problem with asthma happens. When you're trying to blow the air out, the air tubes become smaller in response to whatever stimulus is out there, and you have difficulty breathing the full air out. Hence, you feel that there is tightness in the chest. You feel breathless because you're not able to exhale all the way out. There could be a cough, and it is, by definition, asthma is supposed to be a reversible disease. And so that means when that offending agent is gone, the bronchioles go back to their normal caliber. However, we do see in some patients this airflow limitation can become persistent. And again, we will discuss that more at a more basic level in a little bit. So whenever we talk about a disease, we also look into how prevalent this disease is, how many people have this disease, right? So it is a very common problem. More than 300 million people worldwide have asthma, and about 8 to 10% of US population has asthma. These are a little bit older numbers, but that's the best we have available. And out of those patients, 5 to 10 have severe asthma, which is a difficult disease to treat. And asthma is related with poor quality of life and the higher morbidity and mortality. For quality of life, that you don't feel well, you're coughing all the time, you're short of breath, you can't do what you want to do. Missing school days, missing work, and if the asthma in severe cases, it can be fatal. All right, so general concepts. So this is a busy slide, but just to give you an idea that, different things, right? So allergens, what things are in your environment, the pollution, occupational exposure. Certain people have exposure to certain things at their work that can cause asthma to be triggered, certain chemicals or gases, or sometimes we have people coming in, the people who work in salons with all the perfumes or the hairsprays and things like that. Tobacco is a big one. Infections, they come, so there's a host, and this is obviously there are genetics that play a role into this, because a lot of us do get exposed to this, but not everybody responds the same way. This leads to inflammation, and then the inflammation, obviously some people recover, and again some people recover in different ways, and some can have a normal recovery, some will have the chronic inflammation and whatnot. So this is just an quick overview of that's how this cartoon talks about that at a bigger level. So now we're going to talk about an important concept, which is called, which talks about the phenotypes and endotypes. And before I go any further, I want to ask if anyone has any questions so far. Amna, do we have any questions? Okay, so I'm not hearing anything, so I'm going to keep going then. All right, so phenotypes and endotypes, right? So what are those things? Second, all right. So so phenotype is, first, so endotype. So endotype is how the backstage story of asthma is. What are the different cells that are involved in this? What are the different pathways? But phenotype is what you see when, as in front of you, right? So whether this is an eosinophilic inflammation or neutrophilic inflammation or whatnot, but but the background is what different types of cells are there. Why is this important? It is important because in modern day we have different types of treatments that target different cell lines. All right, this is a picture that just tells us, the grass and the change in seasons and what different allergens are out there that people get sensitized to. So again, everyone is exposed to allergens, but 70 to 80% of people do not have allergies. What could be the different factors? So genetic predisposition. There are different genes that have been identified that that tell us that these people are more are predisposed to reacting towards these allergens. Environmental factors like different viral infections, pets, LPS or lipopolysaccharide exposures. We know that the various viruses have different effect on people, including, COVID has a very a strong inflammatory response, and we saw a significant increase in asthma cases after COVID infection. And so I wanted to put this slide out here so that you guys would have an idea what are the main target or what are the main key players in asthma pathophysiology. So dendritic cells, T helper cells, alarmins, which is one of the famous ones these days is thymic stromal lymphopoietin, TSLP, then some interleukins, IL-33, IL-25, some cytokines, IL-4, 13, IL-5, eosinophils. This might be a little bit advanced information for you, but I think it's good to know that the pathophysiology includes several different cell types, several different chemokines and cytokines and things like that, so that you are aware of these things. And if you come across any articles in, that you're reading or in your books that you read about these things, then you would think about this. Oh yeah, I've heard about this before. So that's how the knowledge starts building up with time. All right, so I put this slide up here just to give you an idea that, how important this dendritic cell is in pathophysiology of asthma. So dendritic cells are one of these cells that we have in our respiratory systems, and it's a very simple cartoon that shows that, and this is the bronchial epithelium with the cilia at the top. That dendritic cell, what it does is it has this, what we call as periscope function. So immature dendritic cells, they intercalate their dendrites between epithelial cells, and which allows the sampling of the airway lumen. So it's all the time, it's just like, sampling the airway lumen to see what is out there. Is there an allergen there? Is there a virus there and whatnot? And it also helps maintain the tight junctions between the cells too, via the adhesive molecules. And we'll see this further down, that once, it's constantly sampling, and then what dendritic cell does further once it finds an allergen in the airway. So this slide tells us that there are different allergens that affect, that have this proteolytic activity that can affect the dendritic epithelial cell interaction. For example, the house dust mites, Aspergillus fumigatus, which is a fungus, then ragweed and birch pollen, cockroaches and allergens. They have different ways of breaking this tight junction. All right. So the common asthma triggers, again, there might be several things that you might be thinking that, there is a repetition, but the repetition is with its different twists, that, how different, what are the different types of allergens, and how those allergens would play a role going further. Now, so the allergens like pets, pollens, molds, dust mites, cockroaches that we just talked about have different ways of affecting the airway epithelium and getting in there and getting an allergic reaction or a chemical reaction, if you will, downstream. And extreme temperatures, very cold temperatures, very hot and humid temperatures. Patients would report, again, that the heterogeneity of asthma, right? So some people would have, they say, oh, I do just fine in winter, but there are people who would say, no, the winter is, I cannot run outside anymore because it's so cold and it just shuts my lungs down when I run outside. Then there are people who say, no, when it's hot and humid, I can't breathe because the temperatures affect different people in different ways. Then the irritants, tobacco smoke is a big one because it causes severe bronchoconstriction. And I still remember a case that I saw, a young kid who was 15 or 16 years old, and he was playing in a soccer field, and one of his friends offered him cigarettes, and he tried the cigarettes. He probably had underlying asthma, and he had an immediate response to that he felt so short of breath, and he felt like he couldn't breathe, and basically went into a severe asthma exacerbation, where his oxygen levels were low, ended up having such a low oxygen levels that he got intubated and had some anoxic brain injury, or the low oxygen levels to the brain and brain injury and whatnot, because the paramedics couldn't get to him in timely fashion. So tobacco smoke, this is an essential thing that we tell our patients to stop smoking, because tobacco smoke also affects the defense mechanism of the lungs too. So we can, the body cannot fight against these allergens and these viruses and whatnot. Burning wood has a similar impact. In certain parts of the world where there's wood is used for cooking, or it's used for warming the houses up, and even here people use the wood burning fireplaces, and if there's not a proper ventilation, we do see patients coming in complaining of more worsening of their symptoms and whatnot. Air pollution, again, in certain parts of the world where there's more air pollution and there's more congestion and overpopulated areas, people have more respiratory symptoms, primarily asthma. Strong odors, patients absolutely have sensitivity towards strong perfumes. Then viruses and upper respiratory tract infections, as we talked about those earlier on, then they have they can trigger asthma too. All right, so this is a very busy slide, and you guys might come across this, I'm not sure at your level, or obviously, going forward in medical schools and whatnot. I'm just going to briefly talk about this and tell you that because I will touch on the treatment or the targeted treatment areas in the next few slides. So here what we're looking at is, again, this is a bronchial epithelium, right? So different types of, as you see, the cartoon tells us that there's viruses, the allergens, and different bacterias, and they disrupt the epithelium, and the dendritic cells get sensitized, and depending on what type of trigger it is, the dendritic cells will present it to T helper cell, which is one of the defense lines of the lungs. And that T helper cell, or naive it's a naive T cell, which will divide into either Th2 or Th1 or Th17, and those T cells will further stimulate the different pathways, either eosinophilic pathways or neutrophilic pathways, and causing at the end, this will cause hyperresponsiveness and bronchial constriction and airway inflammation and whatnot. All right, so these things are important, or this pathophysiology again is important, so that we know how to treat the patients, right? So what exactly goes behind the scene, so we can control those things, we can stop those things and treat or make a treatment plan. So first and foremost is the avoidance of offending agent. Whatever triggers your asthma, that's where the money really is. So I always ask patients that, how does your asthma get triggered? Is it a smoke? Is it the smells? Is it the pets? Do you have pets at home? Cats are very, they trigger a lot of allergic responses in a lot of patients. Do you have cats? Do you have even dogs? And, many a times patients say, oh, I have this dog or a cat for years and years. And it's true that you can have a pet for years and years. You can get sensitized in a later time as well. Then also I ask patients, where does the cat or the dog sleep? Because if the pet is sleeping right next to you, that's a longer time of exposure of all those allergens to you, as opposed to if the pet is sleeping in its own bed or outside the bedroom is even better, and things like that. Do you smoke? How about, are you able to, when you go outside in the cold winter, are you able to breathe fine? Does that affect your breathing? And, the things that we just talked about. Those are the major things that we discussed. It again: tobacco, seasonal changes, pets at home, and any other triggers in terms of having, perfumes, lots of carpets. Do you have carpets throughout? Because no matter how much cleaning you do or vacuuming, carpets have the tendency to hold a lot of dust and dust mites. Heavy curtains have the same issues and things like that. So that's the offending agents that you have to identify the triggers, and then you obviously have to counsel the patients about avoiding them. Then one of the principles of the treatment, what do we give it to them? There's the main treatment or treating agent is steroids, whether they're inhaled or oral steroids. And then in next couple of slides, we'll see what the role the steroids play in this. Bronchodilators, and again, as the name implies, it's these are the medicines that dilate the airways, and there are different kinds of bronchodilators. I just have these acronyms here, but what does that stand for? LABA, which is a long-acting beta agonist, which basically means that these inhalers last for 24 hours or 12 hours. They're long-acting. Then SABA is the short-acting beta agonist, and they last anywhere between 4 to 6 hours. Then there are other bronchodilators which act on long-acting muscarinic agents, which act on different receptors on the smooth muscles of the airways. So again, ICS, or the inhaled corticosteroids, is a treatment of choice for all patients, but the mildest patients with asthma. There's a little bit of difference of opinion depending on which guidelines we follow. And the GINA guidelines that I mentioned earlier on, they talk about the ICS for all patients. And then these are the NEPP, which is the National Asthma Education Prevention Program. They talk about that in mild forms of asthma, you really don't have to use the inhaled steroids. Whereas the GINA prefers to use the inhaled steroids for all patients, and they have their own reason for this. And I just put this questionnaire up there for you guys to know when you will have, when you start your clinical rotation, or when you're seeing a patient, you should be familiar with this test, which is called asthma control test. There are other tests available in the market too, or in the field too, but this is something which is widely used and accepted, which basically has 5 questions that's easy to do and gives you an idea how well or badly controlled the asthma is. And what it's obviously based on recall, and in past 4 weeks, how well your asthma is controlled, right? So if you ask someone in the last 4 weeks, how much of the time did your asthma keep you from getting as much done at work or at home that you wanted to do? So someone says, oh, all the time, that is a problem, right? As opposed to somebody says, oh, a little of time, which is number 4, or none of the time, very good. More than once per day, as opposed to once or twice per week, so not as frequent of the symptoms. Then you ask them about, in the last 4 weeks, how often did your asthma symptoms, which again, as we talked about, wheezing, coughing, shortness of breath, chest pain, chest tightness, wake you up at night or earlier than usual? Again, if it says that's happening 4 or more nights per week, that is a big problem, right? So if it is 2 or 3 nights per week, and once a week, once or twice, or not at all. So it's a very good way of grading someone's asthma. The next 2 questions talk about how often you use your rescue inhalers, how often, or your nebulized medication in the past 4 weeks, how would you rate your asthma control? Not controlled, very well controlled, and whatnot. So it goes all the way. A score of 20 or greater is considered well controlled, because we not at all or whatnot, or rarely or not very often has higher number, 4 or 5. A score of 16 to 19 means it's not well controlled, and less than 15 is very poorly controlled. And it all depends, some of the things about these questionnaires is that how you ask the question from the patient and how well they understand. Sometimes when patients just fill it out on their own, you'll see the response might be a little bit different than when you do it yourself in the clinic. So you just have to be aware of that too, because sometimes, patients come in and they look fine to you and they're talking in full sentences, and you listen to them and their chest is, they're breathing, moving air very good, and there's no wheezing, there's no shortness of breath, and none of those symptoms. And yet they scored like 13 on the questionnaire. What does that mean? Then you go back and ask them that, and then the questions, and then, oh no, okay, I didn't mean this or that. So you always have to not just take the face value and just validate it yourself too. Okay. So it is a busy slide, and but why did I put it here for you guys is to give you an idea again that how asthma is treated. There is a stepwise approach to treatment of asthma, and this is from Global Initiative for Asthma, and you guys can look that up if you needed to study more about asthma or in depth, or wanted to just get an idea. It's very helpful to go through those. They have their own deck of slides and whatnot, and that's where I got this one from. What it talks about, so let's focus at the top of the slide here. 20 minutes, okay. So whenever you see someone, you have to make sure that you confirm the diagnosis, right? So that is the most important thing that you need to do, the confirmation of the diagnosis if it's necessary. Then symptom control, you have to look at the modifiable risk factors, which is, as we talked about the triggers, very important. Can't stress enough on that. Comorbid conditions. You need to figure out if this is really asthma, or if this is heart failure, or could this be something else? Could this be anxiety? Because the breathlessness could come from, there could be other things too besides asthma. Is the inhaler technique good of the patients? Because many a times what we find is that the technique is not appropriate, right? So there are different kinds of inhalers in the market. I'm not sure if you guys have seen any of those. The easiest one is the albuterol puffer, that you take the cap off and you just breathe through that. However, then there are inhalers that, you open thing up. There are disc ones that you move different things around. So cannot tell you how many times it happens that the patients have been using these inhalers for years and years, yet they do not use it correctly. Or when you ask them, have you been using your inhalers? They would say, oh yeah, I use it. And then you ask them, how do you have it with you? Can you show it to me how you use it? I have one time I've seen this, that they didn't even take the cap off and they're using it. Because again, the teaching is so important. The education and teaching is so important. You want to make sure that your patients are aware of how to use this device correctly. And then there are devices which, if your patient has like arthritis in their hands and they're old and it's hard to open the device up, this inhaler up, then you have to make sure you select the appropriate inhaler for them. Then there are times where you see that the patient is not able to, some of these inhalers get triggered when you take a deep breath in, as opposed to, a normal good breath. And some patients might not have that much of the strength in their lungs or in their chest that they can generate that negative force to trigger this inhaler. So that is very important to figure that out with the patients, because majority of the time you'll be able to tease that out. Then, you also, so you assess that, then you adjust for modifiable risk factors, the comorbid conditions. Then if there are any non-pharmacological strategies, like we talked about the pads, we talked about the carpet, we talked about the curtains and, exposure of the smoke or the perfumes and whatnot, then, you adjust the asthma medications. Do you need to go up higher on the doses or lower down the doses and whatnot? Education and skill training, that goes without saying. Then here, you every time you see a patient, you review their symptoms, their exacerbations. How many times did you get? How many exacerbations did you have this year? Sometimes they don't even call you and they go to the local urgent care, and you need to know all of this. That, oh, the patient didn't report to me or didn't come to see me, but they have been seen in the local ERs or urgent cares and whatnot. So you need to know this, so that means your patient is not very well controlled. What else can you offer them? Then you have to sometimes review the side effects. Are they developing any side effects of the medications in terms of, these things have steroids in them, the inhalers have steroids in them. If they're not using it properly, one of the common side effects the patients report is the thrush or the fungal infection in the back of the mouth, which is very painful and unpleasant side effect. You need to know that. You need to assess their lung functions, that how well they're doing. Are they losing their lung function over the years or not? Patient satisfaction is very important. That, are they happy with the treatment? Are they able to do what they wanted to do after you treat them? So just wanted to give you this idea, because it's very important for any level of training that you would know when you're talking, once you start your clinical rotations, or if you're already graduated and starting your residency soon, then the history taking, knowing their symptoms and their medications and how they're taking their medications, what are the different risk factors and triggers and whatnot. Okay. Then we talk about, like I said, different, the asthma treatment is done in different ways or in different steps. And these are the different sort of two pathways that we divide into track 1 and track 2. I think it's going to be a little higher level, but I'll just tell you quickly that, we start with one of the inhalers, the one, and that's where, remember we talked about that depending on what type of guidelines or that you're following, One talks about just for the mild asthmatics, you use the inhaler, which only has a bronchodilator, whereas the GINA talks about the bronchodilator along with the steroid. So that's what basically this means, that, if you have track 1, you'll start out with an inhaler which has an ICS, which is inhaled corticosteroid, and a formoterol, which is a LABA, or a long-acting beta agonist. Whereas in this one, you take ICS separately. You can take ICS separately when you take short-acting beta agonist. So again, so basically, GINA guidelines do want us to take inhaled steroid every time when you need it. Whereas any NAEPP guidelines want us to take just the albuterol alone. But GINA itself also divides into using this special kind of inhaler, which has the long-acting beta agonist, as compared to short-acting beta agonist. Then you put the steroid in it, and it has its own reasoning because of the affordability and the insurance coverage and whatnot. And then if the symptoms are not controlled with these as needed medications, then you go up and you ask the patients to take it every single day, and even when it's not controlled very well, then you go up and add, increase the dose to medium dose steroids. Then in the step 5, you start adding the LAMAs that we talked about, the different kind of bronchodilators with the mechanism of action is different. Then you also, here you start talking about the phenotypes that we were talking about, that whether or not we need to give patients any higher level of treatment, targeted therapies or not. So again, I just wanted to show it to you guys so that you're aware of the stepwise therapies, what the GINA guidelines talk about, the different tracks, and basically the tracks are different only depending on what inhaler you're using. Again, if you look at here, the reliever therapy, they want you to use the same inhaler as reliever therapy, which we call as smart therapy, whereas here you're using the SABA, or the short-acting beta agonist. And again, most of that is something which is driven by availability of the inhalers and whatnot. Okay, so we've talked about steroids and their role. I think I need to wind up pretty quickly here. We only have 13 minutes left. But so the steroids have a major role. Like I said, it's a mainstay of treatment. What do? They reduce the inflammatory cells, right? So the neutrophils, the eosinophils, and all sorts of cytokines and their numbers, and all bloodlines, or all the cells that are involved in this, their numbers get reduced. They also reduce the leakiness in the membranes, and they also increase the expression of the beta-2 receptors, reduce the mucus secretions and whatnot. So it has a significant role, major role. And as we saw one of the slides before, where we talked about the pathophysiology, this cartoon talks about the therapeutic targets in asthma as far as the interleukins are concerned. So you guys might have seen the ads of different kinds of biologic medications out in TV. There are 6 biologics that we have available in the market, and this is not available for use yet. But we have omlizumab, dupilumab, meplizumab, reslizumab, and benralizumab, and tezepelamab. These are the generic names, and there are different trade names that are out there. And basically, they act on different receptors, and they block different chemokines and pathways, and have been very, very, very helpful. Just quickly, some of them would block the anti-IL-5, and some of them will block the IL-4, IL-13. And if we go back here, if you remember, these, there are different blockages up here. That's what they're trying to do, these new targeted therapies. And here too, if you can see, they'll stop the IL-5, IL-4, IL-13, this dupilumab, omalizumab works on IgE, neutralizing IgE. Teslezumab acts at a very, very high level where this TSLP and that we talked about, that thymic stromal lipoproteins, as soon as they're released, it stops all of that. All right, so I'm going to finish up in the next 5 minutes so that we have 5 minutes for questions. And this was teslezumab that we were talking about. It stops right at that level where our famous dendritic cells were starting this inflammatory cascade. Okay. This picture is good for you guys to know. And what we're looking at here is the cross-section of the airways, right? So as you can see, the airway caliber in asthmatics have gone down from being this open, the bronchial tube, from being this open to this small. And so why asthma makes it harder to breathe? No brainer, right? But just, the air enters the respiratory system. The respiratory system starts right from the nose and the mouth and travels to the bronchial tubes. Now it comes down. In non-asthmatic person, the muscles around the bronchial tubes are relaxed and the tissue is thin, allowing for easy airflow, correct? Now, whereas here in asthmatic person, the muscles of the bronchial tube, as you see that what's going on to them, they're tightened and they're thickened, and the airway passages become inflamed, and the goblet cells or the mucosal lining has the cells, the goblet cells that make a lot of mucus, they start making mucus, and the airways get filled with mucus, and it gets difficult for the air to move in and out. So that's what's happening in them. So I think it's a good picture for you guys to keep in mind, and because you will see that patients will be telling you also, oh, I feel like there's something stuck in the chest, it's the mucus, and I just can't get it out because the tubes are so tight. And this is something important for us to know, and what that is, it's a slide of the airways that it talks about the remodeling of the airways, right? So here, you see that this is a normal epithelium, but here you will see that all these smooth muscles around, they have thickened, and they become thickened. A time comes that the asthma is no longer a reversible airway disease. And the smooth muscles don't let the airways go back to normal because they have hypertrophied or have become bigger with time. Okay, so I have a lot more slides, but Anna, should we stop here? Do you have quiz? Because I was going to just touch on Anna, are you there? It's going to touch on COPD, but I'm not sure if we have time. I can't hear you, Anna. All right, so I'm not sure if Amna can hear me. All right, so I wanted to quickly talk about COPD-2, which is another obstructive airway disease, but in interest of time, I'm thinking of skipping over this, or maybe we can talk about this. All right, so this is another clinical case where a 60-year-old guy comes to your office with several year history of increasing dyspnea on exertion, right? DOE or dyspnea on exertion. He reports a chronic cough with minimal sputum production, usually in the morning. It's been persistent for years. Occasional wheezing. 10 years ago, he was diagnosed with touch of asthma. He can no longer walk a flight of stairs without feeling winded. His past medical history is significant for a hernia repair 5 years ago, mild high blood pressure. He does not have any history of atopy, which is basically a history of allergy or sensitive to having seasonal changes, or had asthma as a child. He smokes a pack per day for 40 years, right? So you have to start thinking about, as soon as you know, oh, somebody's smoking for 40 years. What does that mean for this patient? And then the family history, no family history of asthma at all. His father died of lung cancer at the age of 69, and mother has Alzheimer's at the age of 84. So father having lung cancer at the age of 69 also makes you think that, whether or not his father was also a smoker, right? So then the medications, taking multivitamin and the blood pressure medicine. And on physical exam, he has decreased breath sounds with prolonged expiration. These are the breath sounds that you hear, and occasional expiratory wheeze. There are the heart sounds are distant but regular, normal S1 and S2. That also makes you think why the heart sounds are distant. Maybe the lungs are hyperinflated, right? So extremities, there is no cyanosis, no clubbing, no edema. So again, these things are important. If somebody has lower oxygen levels, their fingertips will be blue. The clubbing, we see this, literally the fingertips look like clubs because of the chronic lung diseases, and edema is the swelling in the lower legs. And again, we need to make sure there's no cardiac component to this. And then that's their spirometry. And if you look at this, their spirometry is compared to the Pinkalicious patient that we had in the beginning. It looks abnormal. The FEV1, or the forced expiratory volume, is 52% as opposed to our previous patient, which was 90%. The ratio is also reduced. Their DLC, or diffusion capacity, is also reduced. And they did have a little bit of response to the bronchodilator, about 8% after taking the inhaler. So the question is, does this patient have asthma? What is in the history that suggests asthma? What in the history does not suggest this is asthma? And what in this history suggestive of COPD or emphysema, right? So real quick, obviously the biggest red flag in his history is that he's been a smoker for 40 years and a pack per day. So right away, you'll start thinking about COPD, which stands for chronic obstructive pulmonary disease. And what in his history does not suggest asthma is that he never had a history of asthma per se. As a kid, he was never sick, having the chronic bronchitis, or doesn't have the seasonal allergies and whatnot. So with his what you can think about, well, you can also say, oh, he has wheezing and whatnot. So yeah, so patients with COPD can wheeze too, because it's also an obstructive lung disease. So it is a common preventable, because if you don't smoke, or you're not exposed to smoke of any kind, you probably will not get COPD. And a treatable disease, persistent airflow limitation, it's progressive, and chronic inflammation, and inflammatory response in the airways, and to noxious particle or gases. And it's there's several exacerbation and comorbidities that contribute to overall severity in individual patients. This just, the next few slides will talk about that what are the differences between asthma and COPD, in terms of the history, in terms of when we look at them and the post-mortem patients, that how they differ, what's the difference in their sputum, what's the difference in cellular infiltrates, cytokines, and whatnot. So just to conclude, things about asthma, it is a clinical diagnosis, like how we talked about. You should be able to figure this out from history. The clinical paradigm has evolved over time. The treatment plans have changed over time. It is important to know who has asthma early on, and the treatment is obviously essential, because the treatment helps reduce the morbidity, as we talked about, the remodeling of the airways, and we don't want our patients to have irreversible airflow obstruction. Okay, so with that, we have 1 minute left, and I'm going to stop right here. And if you guys have any questions, please let me know.
Yeah. Thank you so much, Dr. Farooq, for your mentorship and teaching. We can now begin our Q&A session. So our first question for you, are there any lifestyle changes or habits that individuals can adopt to improve their sleep quality without resorting to medication?
Okay, so that question is not related with the talk to the talk, but I'm happy to answer this. So the question is that the lifestyle changes to improve the sleep quality.
Yes.
Okay. All right. So the first and foremost is having a regular sleep schedule. It's a very simple thing, but it goes long ways. The simple sleep schedule, we always tell our patients to pick one wake up time. Going to bed time doesn't impact the sleep a whole lot, but to set your biologic or your circadian rhythm, the wake up time is very essential. So even on the weekends, people like to sleep in and whatnot, which is actually counterproductive to the sleep schedule. So picking up a wake up time, whether it's a 7 o'clock or 5 o'clock, depending on how you time your day, is essential. On the weekends, you can probably push it half an hour to maximum an hour, but if you start pushing your sleep time, or the wake up time, the sleep time gets affected. So the bottom line is having a regular sleep wake pattern dictates your quality of sleep at nighttime. That's number one. Number two, having minimum distractions at nighttime. For example, 20, 30 years ago, we didn't have much of an issue with the sleep because we didn't have the technology at the time, right? So right now, and just even 15 years or so ago, we didn't have the handheld devices, or maybe a little bit, 15 years or so. In the bedrooms now, when we go to bed, the phone is right next to us, and we all use technology till we fall asleep. The bright light of the phones, it does not let us get to the deeper stages of sleep, or does not let us initiate the sleep very quickly. Also, and it makes your brain active too. So one of the things we always tell our patients, not to use any sort of technology, don't watch TV at least half an hour before you go to bed. So that's second time. Limiting the caffeine. And as students, we drink a lot of caffeine all the time, but limiting it, at least trying not to have something after 5 o'clock or 6 o'clock if you want to sleep on a regular time, like by 10 o'clock or 11 o'clock at nighttime. And then, so I mean, those are, and then also trying, and some people have trouble maintaining their sleep. So, they go to bed fine, but then they keep waking up. And once they wake up, they look at the phone, and then they look at the time. Oh my God, it's 2 o'clock. I only have like 3 hours left. I have this test tomorrow, or I have this presentation tomorrow. And that just generates anxiety. So I also tell our patients not to get stimulated in the middle of the night with any, by not looking at the clock, or don't have the clock in the room. If you need an alarm or something, you can put the alarm clock on your phone, put it in the vibration mode or whatever mode or silent mode, and turn the phone's face down so that you don't, if someone is sending you a message in the middle of the night, then you're not, oh, somebody sent me a message, so let me check what it is. So these are very simple things, but they do work on the quality of sleep.
Right. Thank you so much for all that insight. So our next question is, could you share some insights in the latest advancements or any research that you've been exposed to in terms of like pulmonary conditions that you find particularly promising or exciting for like treatment wise?
So that's a very broad question, but yes. So there's a lot of research obviously is happening in different fields of pulmonary medicine. I can talk about asthma, and the biggest things that we've been working on, or there's a big stride towards treating severe asthma or severe persistent asthma. No matter how many inhalers you give to these patients, how many steroids you give to these patients, either they become dependent on the oral steroids, which is in a way, I mean, the oral steroids have their own side effects long term, right? So they thin the bones out, they cause the high blood pressure, they cause the diabetes. There's so many things that can happen with steroids. So that's where all these targeted therapies, or the biologic therapies or injections, are come into play. So there's a lot of work that's still being done on developing new therapies, and these biologic injections that help patients get off of steroids and restore their lung functions and reduce their exacerbations and whatnot. So yeah, so there's a lot of network trials that are going on throughout the country and throughout the world for severe persistent asthma. There's a big trial called PRECISE, and that's working towards precision medicine, that how precisely will treat one's disease, or it's going to be more targeted towards or individualized medicine, so to speak. And there's another one called SARP, which is Severe Asthma Research Program, where again enrolling patients who have severe asthma.
All right. Thank you so much. Those are very interesting. So our next question is, can you discuss the role of telemedicine in the field of respiratory and sleep medicine, especially in light of like the recent advancements in healthcare technology?
Yeah, so telemedicine is so I mean, you can essentially see a lot of patients through Zoom calls or through virtual appointments. For us, I think sleep medicine is easier in terms of seeing someone virtually, that you need to ask the history and you don't necessarily need to examine them per se, although sometimes in sleep medicine too, if patients have so there are different sleep problems, right? So there's a sleep problem where patients have difficulty falling asleep, staying asleep, insomnia. There's sleep problems like sleep apnea, where people actually stop breathing in their sleep, or what we call a sleep disordered breathing. Then there are sleep problems like narcolepsy, where people fall asleep, there's irresistible urge to fall asleep. So those kind of patients, sometimes you need to, patients with narcolepsy, you would need to have them come in and take a look at them, or examine them, do a good neurologic exam and whatnot. But at least for the first time, you're able to sort of scope out things and see what is needed for the patients. And then, in the subsequent visits, you can decide if they need to be seen in person. Same goes for lung diseases too, that, if you have their breathing test available, you have their good history, obviously you can take from virtual exams, you have their imaging available, X-ray, CT scan, whatnot, that you have access to. You should be able to see those patients virtually. And then if you needed for them to come in, you can. I prefer to do it the other way around, that I try to see the patients the first time, and I mean, majority of 99% of the time I see the patients in office. If the patients live far away, then I would do a telemedicine or the virtual visit with them to go over the results of the testing that we did, or to follow up on the treatment plans and things like that.
All right, that makes sense. Thank you. Our next question is, as an educator yourself, what advice would you give to aspiring medical professionals who are interested in pursuing a career in pulmonary critical care?
So it is, I mean, obviously I am in this in this field, so I am biased, but I will tell you this, that it is a type of specialization where you still think about the patient as a whole, right? So certain specialties, they focus on just that organ process, and especially in critical care, when you see someone who's critically ill, and then they come, you're seeing them in an ICU or an emergency room, you have to think about everything. Why is their mental status changed? Is this something neurologic? Is this something related to liver? Is this some sort of drugs or intoxication? And so you just don't think about one, or is this, the effect of the sepsis, or, are the lungs involved or whatnot? So there could be so many possibilities. So that makes you think about the patient as a whole, and you don't get hyper focused on one thing. So I like that part of the specialty, that it makes me think about everything, and it makes me feel like that I'm a good doctor. I think about everything, not just my only organs. Even for the lungs too, when you think about lungs, you have to think about the heart at the same time. You have to think about the other medications. You have to think about the rheumatologic diseases that are associated or connected with lungs and whatnot. So, or sometimes the liver has an effect on the lungs and things like that. So I like that part of the medicine. It is very exciting. The critical care part is very exciting, and that's the majority of the time when people come in the field that I am in is because of the excitement of the ICU and when you save someone's life, and patients come in where you feel like that they're not going to make it, but then you treat them and they get better and they walk out of the ICU or they get transferred to the floor and whatnot. So those kind of things, excite us when we decide about the field. The pulmonary part of the field also, because you see patients in the clinic and patients develop this relationship with you, and they're happy, they're very grateful what you did for them. So all those things. I do believe that the people who want to come in medicine, are the basic premise of this commitment is that we all want to help someone, right? So we have this feeling that we want to help people feel better, and you touch the patients in the ways that no one else can touch, right? So it's a very personalized thing. People open up to you about their history. They would tell you things that they would not tell to somebody else. I mean, you meet somebody for the first time, they're a complete stranger, but by the time they walk out of your office, you feel a connection with them. They've trusted you with their body, with their history. It's a beautiful. I mean, overall, medicine is a beautiful field. It is very gratifying in terms, the response that you get from your patients, and when you feel like you have helped someone feel better. You have whether it's whether you're a psychiatrist or whether you are a pulmonologist or hepatologist, whatever it is, you help patients in different ways. And I think that's the most beautiful part of medicine, as opposed to if you were to do any other type of job.
That's very inspiring. Thank you so much. So for our last question, how do you manage your work-life balance?
That's a tough one. As you might have seen your mom too, that's like a constant struggle and an effort, right? So it's like, but it's doable as a woman. I do feel like women are stronger than men. I don't want to start this argument, but it is true, because I feel like we are blessed having this talent of multitasking. But there are challenges. I mean, it doesn't come, you compromise on your sleep, you compromise on a lot of other things in your life that you would otherwise want to enjoy, but it's doable. You have to be more disciplined, and just, have lots of checklists and making sure things get done in timely fashion. But I mean, it's doable, and it's a great inspiration for the kids too, that you can do all of this, help other people at work, and then you come home and there's another job at home that you have to do very well, just as well as you did during the daytime. So yeah, I mean, it takes a lot out of you, but I don't know if I'm really answering this question, but I think what works for me is to have some sort of like an order in my day, that what do I need to do today, and what do I need to do, work-wise? What do I need to do when I come home today for the kids and for myself? And sometimes, checklists definitely help. Then putting hours late at night, or sometimes waking up early in the morning. We've done that several times, when you have exams coming up, or the board exams that we have to take every now and then everybody's sleeping. You wake up super early and get things done and things like that. Yeah, and then your family helps out too. So it's a team effort, helping get things together.
Yeah, that makes sense. I'm sure we all understand managing like your work job and your home job.
Right.
All right. Thank you so much, Dr. Farooq. Those are all the questions we have for today. I'd love everyone to please give a warm thank you to Dr. Farooq in the chat box for this very informative session and Q&A session. Thank you.
Very welcome. Have a good day, everyone.
Thank you.
Take care.
Thank you. So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. And that link is being sent in the chat now. Now on to our next session dates. These dates will also be posted on our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all next Saturday, October 14th at 10 a.m. Eastern Standard Time for our next Physician of Cardiopulmonary Month. So thank you so much, everyone, for attending today's session, and we hope to see you in upcoming ones as well. And this concludes this week's